So I'm going to take this opportunity to start this lecture by introducing Dr. Cesar Netto, who is an orthopedic surgeon specialized in foot and ankle surgery. He serves as an assistant professor at the University of Iowa, Carver College of Medicine in the Department of Orthopedics and Rehabilitation. He had 4 clinical fellowships in orthopedic foot and ankle surgery, so it's possible he loves foot and ankle even more than I do. First at the University of Sao Paulo in Sao Paulo, Brazil, at the University of Alabama in Birmingham, and the Hospital for Special Surgery in New York City, and finally at MedStar Union Memorial Hospital in Baltimore, Maryland. In his research, Dr. Cesar Netto specializes in foot and ankle surgery disorders and imaging of the foot and ankle with focus on, as we'll see, progressive collapsing foot deformity or flat foot, ankle arthritis, please mute your mics, ankle syndesmotic injuries, weight-bearing computed tomography, and Achilles tendinopathy. And with that, I'd like to welcome Dr. Cesar Netto to teach us.
Well, good morning or good afternoon, depending where you are. It's still morning for me here in Iowa. It's a great pleasure to be here. Thanks for the invitation, Hillary, for giving this talk. It's for sure my main 2 passions in my career and in my practice. And I'll try to share with you guys a little bit of my story with flat foot or progressive collapsing foot deformity, as you're going to see that we recently proposed this terminology and the weight-bearing CT. So you can stop me anytime if you have any questions. It's kind of a dense research stuff here, so if you have to ask me questions, you can stop me anytime. Here we go. So first, talking about conflicts, I do have conflicts of interest with weight-bearing CT. I work with one of the weight-bearing CT or the companies that commercialize weight-bearing CT in the U.S. and around the world. And I'm also treasurer of the International Weight-Bearing CT Society, and they're both are directly related to this talk. But I like to say that more than my financial conflicts, I think my passion for cone beam CT and weight-bearing CT and flat foot or progressive collapsing foot deformity is probably the most important conflicts of this talk. And then talking about the flat foot, the terminology and the presence of flat foot. I mean, flat foot is around for a long time. Recently, doing a literature review, I found that the oldest proof of an existence of a flat foot in the humans is in Turkey, in the marble world, where there's actually a lot of studies calculating the foot arch index in this footprint that is in the marble world, and the experts agreed that this was a flat foot, and we have a proof from the 1st century after Christ of a human flat foot, as we can see here. The terminology, we use different names for this pathology. We can say it's flat foot, as most of us would say. Initially, this was blamed on the posterior tibial tendon being the main driver of the deformity. So posterior tibial tendon insufficiency, posterior tibial tendon dysfunction were used for a long time. We actually know currently that the posterior tibial tendon, the degeneration doesn't happen that frequently as we thought. And then when it happens, it's not as bad as we thought in most of the cases, or at least a huge part of the patients. So we have been trying to go away from this terminology, and we know that the posterior tibial tendon potentially can be just the tip of the iceberg of a very complex 3-dimensional deformity. More recently, acquired flat foot deformity was probably the most used terminology, and as we're going to see here, with the amount of in the body of literature recently about the problem, we believe that this terminology also does not describe well the problem. Something happened here. We know it's the pathophysiology is multifactorial. So as we just discussed, the posterior tibial tendon being the major dynamic stabilizer of the longitudinal arch was blamed for a long time. That's why the posterior tibial tendon dysfunction came from. But there are tons of other static soft tissue restraints, such as I would like to highlight the spring ligament complex, the talocalcaneal interosseous ligament, the cervical ligament, and the superficial deltoid ligament. And I would say also the deep deltoid ligament, but others such as long and short plantar ligaments, the plantar capsules of all the medial longitudinal arch joints, the plantar fascia, so on and so forth. And we don't really know exactly what happens first, so it's kind of the chicken or the egg thing. So this would be the main diagnosis or the main assessment of patients with flat foot or adult acquired flat foot deformity or whatever we want to call it, where we would look into conventional radiographs and clinical assessment, mostly looking into traditional findings such as abduction of the midfoot, forefoot by uncoverage of the talar head, the hindfoot valgus assessed here by the hindfoot alignment view, or clinically where you can see that the alignment of the heel and the leg. So the heel is lateral to the leg. There's this lateral angulation with the famous too many toe signs with the abduction of the forefoot and the collapse of the longitudinal arch, marked by traditionally by the Meares angle or the talus first metatarsal angle. We can see a break here in the axis of the talus and the first metatarsal. But can we really understand the complexity of this deformity, where pretty much every single joint of the hindfoot and midfoot are involved? Can we really get the proper assessment of this deformity using just physical exam and conventional radiographs? My biased opinion is that no, we cannot. The problem with the flat foot is that we know that not all flat feet, or let's say a low arch, are not pathologic. Kids have flat feet, and it's part of the development of the foot. Just making jokes. Some animals have flat feet, and they don't seem to hurt. And there's a lot of professional, high-class, elite athletes that have flat foot, and they were able to perform, such as Usain Bolt that we're seeing here. So the $1 million question, or let's say the $1 billion question, would be when patients come to your office and they say, well, I have this flat foot. I know I didn't have a lot of pain, but now it's hurting a little bit. Do I need surgery? And the traditional teaching for residents, medical students, and fellows was that, and I'm just asking the question here, is it okay for us to say to patients, well, if it doesn't hurt that much, we should probably do anything. We shouldn't do anything. We should just wait. So can we really let it go? And if you do it, if you let all flat feet that come to see you in clinic, they are not super symptomatic go, you're going to for sure watch some of them collapse, and you're going to waste the window of opportunity to do procedures or at least more invasive conservative treatment to avoid progression of the deformity potentially, and you will get to crazy deformities such as this one where the ankle is gone, there's arthritis in the ankle, there's huge subfibular impingement here with potential arthritis of the subtalar joint as well. So if you let every single case go, you will for sure have disasters like this. So it would be great if we could have like a crystal ball to identify the patients that need something to be done sooner rather than later. And to be able to tell the patient when should we push the button for surgery, and or at least for a more invasive conservative treatment with a more stable brace or something like that. So I'll try to show you here. I like to divide my my career to date into 3 phases, and I think Hillary mentioned that I spent some time in Baltimore, in New York, and now I'm in Iowa. But I think those 3 places influenced my my passion for flat foot and for weight bearing CT. So it started in 2014 when I was doing research with Dr. Liu Shan at MedStar Union Memorial Hospital. When I got there, I was doing part of my PhD that had nothing to do with flat foot or weight bearing CT. And then I was actually doing an animal model of Achilles tendinopathy. And then Dr. Sean told me, well, look, you're welcome here. We would love to have you leading some stuff that we're doing. We're doing a lot of things. So you can go to my office. There's a whiteboard there. All the ongoing research is there in that whiteboard, so you can choose whatever you want. And then when I went there, it was kind of like this whiteboard, completely messy. And then looking to the whiteboard, I found this weight-bearing CT that I didn't even know it existed. And then said, well, I always liked imaging. It also said flat foot just below weight-bearing CT. So I said, well, weight-bearing CT, CT with weight, that's very cool for foot and ankle. I didn't really know what was it, but I loved it and said that's the one I'm gonna go. And I really think that things happen for a reason. It ended up being the main driver of my career. And then he said, well, if you want to work with the cone beam CT or the weight bearing CT, you have to go to Hopkins because that's where the weight bearing CT is. And go meet Dr. Shepard DeMary, that is a radiologist at Hopkins, and I'm sure you guys know him. I think we were supposed to have Jan Fritz here as well, another radiologist that helped me a lot with a different subject with matter artifact reduction MRIs. That was also there at Hopkins, and we interacted a lot. But DeMary was the main guy for the weight bearing CT, and then I that was the first time I got in contact with the CBCT at Hopkins. They had this prototype that were doing a lot of research, and I can tell that was for sure love at first sight. And then Dr. DeMary told me, well, look, we don't really know exactly how to go from here because there's not a lot of literature. And so why don't you go look into the literature and come back with a proposal? And then this is actually the print screen of what the presentation that I gave to Dr. DeMary back in 2014. And what I told him is that, well, the literature is pretty much for flat foot is based on two-dimensional imaging, based on X-rays, and we know the limitations of that. We knew all the measurements, traditional measurements. I would say, like I said, the talus first metatarsal angle, the calcaneal inclination angle, the talonavicular coverage angle, and maybe the kite angle or the talocalcaneal angle were the most commonly used and referenced in the literature. There was also some good literature for simulated weight bearing with some apparatus that I'm sure you guys know, such as those two examples here that I'm showing, where they would kind of compress the foot, trying to simulate the weight bearing, but good literature out of this, and also some literature using this Philips Aliva system that would provide some standing CT-like imaging, and most of this research came out of HSS. And I ended up spending time at HSS with Dr. Ellis and Dr. DeLand, and even Dr. Ellis makes fun saying that he doesn't know how the ethics committee allowed him to put patients on a cliff, on the edge of a cliff, like they had to stay for this imaging. And then I told Dr. DeMary, I said, well, we have much more questions than answers, so I think we should start on a step-by-step. We should prove the obvious first because there's not a lot of data in the literature. So we decided to go on a step-by-step. And then this was the first publication out of the series that we started. We ended up being able to publish at JBJS back in 2017. It was a prospective cohort of 20 patients with flat foot, and we looked into all the measurements described in the literature for CT scan simulated weight bearing CT and traditional conventional MDCT, non-weight bearing. And we did a total of 19 measurements. What we wanted to show was pretty much the obvious, was, well, when you put weight, does it change the measurements? It would make sense that it would change, but we had to prove that. So out of all those measurements, we found that all of them except one, the calcaneal inclination angle, in flat feet patients, when you put weight, the measurements will change. Or in other words, the foot will collapse with the weight bearing as we would expect. In parallel, when I started submitting the abstracts for conferences, we ended up submitting abstracts for the European Foot and Ankle Surgery meeting, and Dr. Martinus Richter, that was a past president of the European Foot and Ankle Society, he had a lot of interest. He was actually the first person in the world of having a CBCT for foot and ankle in his clinic. So he was in love with the imaging since 2012. And he put all of us together, all the people that submitted abstracts with weight bearing CT. And this is the picture of the meeting that was the embryo for what became the weight bearing CT Society that we currently have, mostly we had some radiologists participating, including Dr. DeMary and Joan Carino from HSS, but mostly the members are mostly foot and ankle surgeons. But I would strongly invite you guys to be part of it, and I'll give you the website address for you to join us and to participate. We've been doing pretty cool stuff, and it became a formal, very active society studying weight-bearing CT, and now we're getting guys from the knee, from the joint replacement, from sports meds, and now that the cone beam CT is going up to the knee and to the hip. We continue to do the research with Hopkins and the flat feet patients. So the second one that we wanted to do was, well, now that we showed that the weight bearing is important, we wanted to see if people with different expertise would be able to do the measurement. So we compared medical student, ortho resident, and a fellowship trained foot and ankle surgeons doing the measurements, and we showed that the reliability for the measurement was very good, good to excellent for most of the measurements. And you can see a parallelism plot here of the measurements of 3 readers, the 3 different experienced readers. But we noticed that when you put the talus in the measurement, because people put this line in the axis of the talus, so defining the axis of the talus is very difficult using a single cut in a sagittal plane here, for example. We show that every single time that you include the talus, then the reliability would not be that good. It would be just fair reliability for the measurements that involve the talus. We were also looking into hindfoot alignment. That is something that people really pay attention for flat foot. So what we did was we compared a clinical assessment by the senior surgeon, by Dr. Sean, looking to the patients, and this was perspective as well. And we did different ways of measuring hindfoot alignment using the cone beam CT or the weight bearing CT, looking into soft tissue alignment and bone alignment using different landmarks. And what we showed was that first, depending on the landmarks you use, the measurement is going to be different. So that is also pretty obvious. So if you use different landmarks, the measurement is going to be different. And most interestingly, we found that the clinical assessment underestimates the bony deformity by at least 7 to 8 degrees here in the weight bearing CT, and you're going to see that we did the same for X-rays as well. So when you see a patient clinically and you go there and you eyeball it, you say, well, this patient has about 15 degrees of valgus, you are underestimating the real bony deformity that you will see in the imaging. We also wanted to compare the measurements that we were doing in the weight bearing CT with X-rays, because that was a frequent question from people that don't have access to the weight bearing CT. So we did a total of 10 measurements comparing sagittal and lateral views of CT and X-ray and axial and AP measurements as well. We didn't do coronal because we don't have a good coronal view for X-rays other than the hindfoot alignment view. And we showed that they are different. So out of the 10, 5 of the measurements were statistically different. And we cannot say which one is right or which one is wrong, but we just can say that they're different. So it depends on the landmarks, probably the landmarks you're using when you're doing the measurements with the cone beam CT or the weight bearing CT. The landmarks are different, so you're getting different results, as we can see here. The second phase started at special surgery. I like to say that special surgery is for sure the mecca of the flat foot, and that is because of Dr. Deland, Dr. Ellis, and also the radiologists involved with Dr. Deland's and Dr. Ellis' research, such as Holly Potter and Caroline Sofka, just to reference 2 names. When I got there, the first study that we did was similar to what we did with the weight bearing CT at Hopkins, but we did a very precise way of measuring hindfoot alignment using pictures like we're showing here. So we measured 2 ways of doing the hindfoot alignment in a very methodological way, and we compared that with hindfoot alignment assessed by the hindfoot view of conventional radiographs. And again, similar to what I showed you with the weight bearing CT, we showed that those are the 2 clinical assessments, and this is the hindfoot alignment angle measured in the X-ray. We again showed that when you look to your patients clinically, you're underestimating the bony deformity. And as I got more experience looking to the images, then you start having more ideas. And I wanted to see, I said, well, if I want to, where do I want to go with this? Where do I want to put my efforts? And I said, well, if I want to be really simple, and what the cone beam CT or the weight bearing CT for foot and neck, what was the most simple thing that it brought to the understanding of this pathology? That is the coronal plane. And just being very simple here. So this is the same patient. As you can see, when you look to the hindfoot alignment view in the x-ray, you cannot really see what is going on in the subtubular area. And when you see this patient, the cone beam CT, you can see the obvious subtubular impingement that this patient has that couldn't be properly assessed with the conventional radiographs. And then I wanted to use all my as I acquired the expertise with the images, and I was getting more familiar with the literature, I wanted to say how can I help with all these that I've been doing. So I want to share with you 5 papers, 5 studies that influenced my the way I ended up following with my research. And this is the first one. It's probably the most important one. This was published back in 1999 in JBJS by the Seattle group by Dr. Sanjorgen. And they introduced the concept of peritalar subluxation that I think is very, very important. So they did, using simulated weight bearing, they looked into the coronal plane views of the hindfoot, and they kind of marked the extension of the posterior, anterior, and medial facets of the subtalar joint in the talus and in the calcaneus. And what they showed is that comparing flat feet and controls, as you can see here, there was a significant decrease in the overlap of the facets of the subtalar joint in the flat foot when compared to the controls. And if you pay attention here, you can see that the decrease in the overlap is more significant in the anterior and medial facet than it is in the posterior facet. But both are have the decreased overlap, as we can see here, and that was significant for both. But they did not compare the differences between posterior facet and the combination of anterior and medial facet. But this concept of peritalar subluxation, in other words, like I said, is much more complicated than just a collapse of the arch. The whole foot is dislocating or subluxing underneath the talus. The second study by the same group out of Seattle, using the simulated weight bearing CT, they introduced the concept of sinus tarsi impingement. That is an extraarticular impingement of the lateral process of the talus into the G-sine angle of the calcaneus, as we can see here. And they showed that 92% of the flat feet patients would have that, and none of the controls would have it. The other concept that is very important is the concept of subfibular impingement. That is the impingement between the fibula, distal fibula, and the calcaneus, as we can see here. And they showed that 66% of the patients with flat foot would have it, and only 5% of the controls would have it. And more importantly, in my opinion, they showed that every single patient with subfibular impingement also had sinus tarsi impingement, but the opposite was not true, giving an idea that potentially subfibular impingement would happen in a later stage of the problem. It would be more important and more demonstrate more the severe deformity when compared to sinus tarsi impingement. The third study is a combination of HSS and the Seattle group. So they were looking into the anatomy of the posterior facet of the subtalar joint in the midpoint of the sagittal, the longest sagittal diameter of the posterior facet. And they described this angle that is an angle between the talar dome and the inferior aspect of the talus at the posterior facet of the subtalar joint. So between the facet of the posterior facet of the subtalar joint in the talus and the talar dome, there would be an intrinsic angulation of the talus that potentially patients had that since not when they were born, because when the bones are growing, you can definitely change this. But once they're adults, this should be fixed. They shouldn't have a difference in the angle between the upper part and the bottom part of your talus. And so they were talking about potentially having an intrinsic malalignment in the bone that would put you in higher risk of having collapsing deformity. As you can see here, the flat foot patient has a much more inclined posterior facet when compared to a control patient. And they showed that in both flat feet and control patients, as you move in the posterior facet from anterior to posterior, the angulation goes from less valgus to more valgus in both controls and flat feet, But controls, they start in varus and they go into valgus in the posterior aspect of the posterior facet. And flat feet, they already start in valgus and go into more valgus as you go posterior in the posterior facet. The HSS group published that this is the fourth paper. They used that concept to compare the measurements in flat feet and control patients, and they come up with this measurement, this threshold value that I really think it's important for us to understand that, where they showed that patients that had an intrinsic angulation or an angulation between the dome of the talus and the posterior facet in the talus, if you had more than 17 degrees, that would be an important threshold to divide patients with symptomatic flat foot and controls. So in other words, if you have more than 17 degrees of angulation, you have higher risks of developing and progressing deformity. The fifth paper, or the fifth study, was out of France and UK by Dr. Francois Lins. That's a great friend. And it's not directly related to flat foot, but it's a better way, in my opinion, for three-dimensionally measuring alignment. So he described the foot and ankle offset, that is the relationship between the center of the ankle joint and the foot tripod, marked by the first metatarsal head, fifth metatarsal head, and weight-bearing point of the calcaneus. So the offset will be the relationship between the tripod and the center of the ankle joint. So you go there three-dimensionally and you harvest the coordinates for the weight-bearing point of the first metatarsal head, weight-bearing point of the fifth metatarsal head, weight-bearing point of the tuberosity of the calcaneus, and then you mark the center of your ankle joint, and the software will give you this. It's going to calculate where M1, head of the first metatarsal, M5, head of the fifth, C is calcaneus, F is the bisecting line of this tripod, where biomechanically would be a perfectly aligned ankle, and T is where the center of your ankle is actually lying. So you can see here that the ankle is medial to the foot, and he showed that in normal patients, the foot and ankle offset would be, it's measured in percentage, because it's you divide by the length of the foot to give you a normality. And if you have up to 5.2, you would have a normal hindfoot valgus alignment. Negative is varus, or in other words, the foot is lying medial to the center of your ankle, and positive is valgus, the foot is lying lateral to the center of your ankle. So this, I think it's a better way of understanding the whole three-dimensional deformity rather than just measuring a hindfoot alignment angle, for example. So, and then using all that, I really wanted to use the concept. I do think we have to be dreamers. We have to try to help patients and come up with better solutions. And I really like the idea of having thresholds. I think it's important for us to have these threshold numbers that could potentially divide patients, and you could give more data to your patients saying, hey, well, you have higher chances of having bad collapsing or your deformity to progress. So we should keep an eye on you. We should follow up closer and make sure that this is not going in the wrong direction. And this is very common in medicine, as we know. For internal medicine, for example, if you have an HbA1c of more than 6.5, you're going to get treatment. If you don't have, you don't get the treatment. So why can't we have this for orthopedics as well? And so I decided I would go into that route and try to find predictors of progressive deformity. So using what Dr. Sanjorgen published in 1999, I started paying more and more attention to the medial facet of the subtalar joint. And this is the same patient here. You can see that the posterior facet doesn't seem to be a lot subluxed. But when you see the medial facet, and this is just a zoom in, you can see the amount of subluxation of that of the medial facet of the subtalar joint. And so I went there and I did a case control study that was published at JBJS 2019, where I measured the amount of subluxation of the medial facet comparing controls and flat feet patients. And you can see here just examples of the controls where the facets are well opposed to each other, and comparing to the flat feet patients where you can see the significant subluxation of the medial facet. And what we found was that the average subluxation in my cohort of patients was 45% subluxation in a medial facet for flat feet and only 5% in controls. And we found that this was a coincidence, but same number that HSS found for the other angulation that has nothing to do with what we're looking here. But if you had more than 18% of subluxation of your subtalar of your medial facet, that number was 100% specific and 97% sensitive for symptomatic flat foot in this specific cohort. We also wanted to validate the use of the foot and ankle offset in flat feet patients. So we did a retrospective study with 113 flat foot patients where we measured the foot and ankle offset, and we measured tons of other conventional measures in the weight bearing CT, as we can see here. And what we found was that 4 measurements would explain 80% of every single change in the foot and ankle offset. Which measurements were that? The hindfoot moment arm, that is a measurement of hindfoot valgus. The forefoot arch angle, that is a measurement of medial arch collapse. The talonavicular uncoverage angle, that is a measurement of forefoot abduction. And the subtalar horizontal angle, that is a measurement of peritalar subluxation. So in other words, when you do the foot and ankle offset, because it is a three-dimensional measurement where you're harvesting 3D coordinates of the tripod and 3D coordinates of the ankle joint, you're assessing all those 4 measurements of deformity in different planes, like the coronal, axial, and sagittal planes, as we can see here. So we're assessing hindfoot valgus, arch collapse, forefoot abduction, and peritalar subluxation. We also wanted to use the foot and ankle offset for see how foot and ankle offset would behave in a surgical setting, and also wanted to compare that with patient-reported outcomes that at the end of the day would be the most important part. So we did a prospective study with 19 patients that had weight-bearing CT before and after surgery, and we measured the PROMIS and the foot and ankle offset. So we showed that as expected, when you do surgery, you correct deformity. And so we were able to bring the foot and ankle offset down from an average of 9.8%. Remember, the normal value is up to 5.2, and we brought it down to 1.3%. That was a mean improvement of 8.5%. We also had significant improvement of PROMIS for all the patients except the PROMIS depression subscale. But when we looked into correlation between improvements in the foot and ankle offset and improvements in the PROMIS, we did not find significant correlation. So there was no direct correlation between PROMIS improvement and foot and ankle offset improvement, even though both of them got better after surgery. So there's a lot of variables that influence PROMIS and patient outcomes, and correction of deformity only didn't seem to correlate directly, unfortunately, for the authors. We also wanted to look into the correlation between the findings of marker of severe deformity in the weight-bearing CT and what was going on with the ligaments and the soft tissues in the MRI. So we did that study that was recently published, foot and ankle surgery in December 2020, where we did 54 patients that had weight-bearing CT and MRI performed. So we looked into markers that I just introduced to you, the sinus tarsi impingement, subtalar joint subluxation, and subfibular impingement in the weight-bearing CT. And then in the MRI, we used different readers. There were 2 radiologists from HSS, Dr. Sofka and Dr. Graditzer. So we looked into every single soft tissue, but I'm highlighting here the posterior tibial tendon, the spring ligament, and the talocalcaneal interosseous ligament. So what we found was that sinus tarsi impingement, that is probably the less severe marker of deformity here, was only correlated with the generation of the posterior tibial tendon. We found a subtalar joint subluxation that is probably a marker of a little bit more severe deformity than sinus tarsi impingement, was only correlated with the generation of the spring ligament for both the supermedial and the inferior bands of the ligament. And most importantly, that subfibular impingement was only correlated with the generation of the talocalcaneal interosseous ligament, as we can see here. And that would mark, in my opinion, that when you have subfibular impingement, you have a more severe, potentially multidirectional instability, because then you don't have real connection between the talus and the calcaneus. And then your calcaneus will start not just rotating, but it will start translating towards the fibula. And that will be potentially, you should consider, in my opinion, when you have subfibular impingement, you should consider a subtalar joint fusion because the connection between talus and calcaneus is not super good anymore. In light of all the data that we had in the literature recently, we ended up getting together and we organized a flat foot consensus meeting that happened in New York City at HSS back in 2019. We wanted to change the nomenclature, like I said. We didn't want adult and we didn't want acquired because patients that have flat feet when they're during childhood, they have higher risk of having a collapsing deformity when they're adult, and that is for sure. So it might not be acquired, and it might not just happen when they're adults. We wanted to remove flat foot because in our opinion, it underestimates the problem. It's not just a collapse of the arch. It's not just a flattening of the arch. It's much more than that. It's a collapse of the whole foot underneath your talus in the best scenario if your ankle is not involved. And we wanted to remove posterior tibial tendon because as I already said, we know that posterior tibial tendon is just the tip of the iceberg. So we came up with this new terminology of progressive collapsing foot deformity, or PCFD. So if you have a flat foot, that's okay. That's not pathologic. But if you have a flat foot that is progressing, then you have progressive collapsing foot deformity, and that's the problem. Those are the patients that we have to identify and act sooner rather than later. We also proposed a new classification system where we wanted to remove the idea of the Johnson-Strom and the Johnson-Strom modified by Meyerson classification, where stage 1, 2, 3, 4, where you have to go through every single stage to get to stage 4, where your ankle would be involved. So we changed that. So you're either flexible or rigid, and that would be stage 1 and stage 2. And we do think that unless you have something like a tarsal coalition that has nothing to do with progressive collapsing foot deformity, you have to have a flexible deformity first so you can get to a rigid deformity. And we came up with classes where we want people to look to the deformity and describe what they see. So the classes, they happen concomitantly. So you look to your patient, you look to your x-ray, you look to your weight-bearing CT if you have it, and you describe what you see. So if you have hindfoot valgus, you're class A. If you have midfoot, forefoot abduction, you add class B. If you have forefoot varus, medial column instability, you add class C. If you see signs of peritalar subluxation that we just discussed, such as subtalar joint subluxation, sinus tarsus impingement, and subfibular impingement, you add class D. If you have ankle valgus, if you have ankle instability, you add class E. So you can be a 1AC, you can be a 1ABCDE, you can be a 1AE. So you just see what you can examine, and you describe what you see. And we do think that is a better classification system, even though we know there's no perfect classification system. We also discussed the role of the weight-bearing CT into all this. And even though we cannot, it's not available for the majority of the services at this point in the US, and even worse, a scenario outside of the US. But if you have a weight-bearing CT, you should be using that at least for planning surgery for your patients, because it does change the assessment. Even though we cannot force people to use weight-bearing CT, the concepts of peritalar subluxation should be looked into conventional radiograph and into your physical exam. So keep in mind sinus tarsus impingement, keep in mind subfibular impingement, and keep in mind peritalar subluxation marked by subtalar joint subluxation, either in the posterior facet or in the medial facet. The third phase started when I started my job here in Iowa, and we started a lab at the University of Iowa Orthopedic Functional Imaging Research Laboratory, and I want to acknowledge my international fellows, Nassimi, Mansour, and Mathieu, that are doing a great job here in the lab, and also Kevin Deburn, that is the PhD that runs the lab with me. So we continue to look into the things that I'm showing here. So we started by comparing, as I showed you, the subluxation of the medial facet and the posterior facet. So we did a 76 patients, and we just did exactly the comparison that we observed before, that the subluxation in the medial facet was more severe, but we never proved that. So when we looked into the same cohort of patients with flat foot we found that the average subluxation of the medial facet was 35% or 36%, and the average subluxation of the posterior facet was 15%. And the explanation for that, the anatomy in the biomechanical books showed that the center of rotation of the subtalar joint is laterally positioned, so close to the lateral process of the talus, especially when you have sinus tarsi impingement, where you have bone-on-bone hitting here. So when you have that and you have a rotational deformity, anything that is far away from the center of rotation will have more displacement, linear displacement in a rotational deformity because it's far away. The lever arm is longer, so the medial facet is positioned more medially to the center of rotation than the posterior facet, and that would be the explanation why you could see the subluxation in the medial facet better than you can see in the posterior facet, even though they're both happening at the same time. It's just a better marker and could be potentially an earlier sign of progressive deformity. We also started working with bone segmentation manually, and also we're working on automatic segmentation. And we wanted to look into the paritalar surface, not just in one single cut in the sagittal or coronal planes, but we wanted to see the whole extension of the paritalar surface. So we started using distance mapping that will calculate the distance between two opposing bones or two opposing surfaces, and you will measure that for 1,000 points. So we published recently in Foot and Ankle International, January 2021, a case control study with 20 progressive collapsing foot deformity patients and 10 controls. And we measured the distance maps in the subtalar or the paritalar area, not just the subtalar joint, but in the posterior facet, in the medial facet, in the anterior facet when the anterior facet is present, but also in the sinus tarsi area. So the distance maps, so if you have between 1 and 4, it's a normal distance between two opposing articular facets. So when you see blue, that means blue is good, blue is okay. So you have normal interaction between the facets. If you see red, is because it's too close. It's either arthritis or impingement if you're outside of a joint, if you're in a non-articular area. So you can see here in a progressive collapsing foot deformity patients, you don't have any distance maps in the medial facet because they're not articulating, they're subluxation. Then you have a lot of bone-on-bone impingement and increased coverage of the sinus tarsi consistent with sinus tarsi impingement. You can also see that a huge part of the posterior facet doesn't have a distance map there because there's no opposing facet on top of it. And we just playing with the colors, we came up with the idea of the coverage maps where we just changed the thresholds. So if you have more than 4 millimeters distances, now you're going to see that in a pink color. So everything that is pink now means that if you are in an articular region, that means that there's no opposing facet in less than 5 millimeters distance. So you can see the almost full subluxation of the medial facet. You can see a lot of subluxation of the posterior facet, and everything that is blue means that it's normal if you're in a joint level. But you shouldn't have any blue in the sinus tarsi area. So you have increased coverage in the sinus tarsi area compared to the controls. And you can see the red is still impingement. So you can see the sinus tarsi impingement there. So it's a much more complete way of assessing what we just discussed with the other publications. And we showed that on average, the coverage of the medial facet would decrease 47% in progressive collapsing foot deformity patients when compared to controls, and the coverage of the sinus tarsi would increase in progressive collapsing foot deformity patients up to 286% in PCFD compared to controls. I'm not going to go into the details of this. So where we're going now, where are we heading with this? So as I mentioned, we're working with the companies to develop automatic segmentation of the foot and ankle bones, because if you can segment bones automatically, that will facilitate the assessment. As you guys know, that to segment the bones manually, it can take up to 4 hours, even if you're just doing the hindfoot bones. So if you can do that automatically, that would be a game changer in the assessment. And we're also playing with, once we have the bone segmented, we're playing with the distance and coverage maps. As you can see here, this is a video video representation of a normal foot becoming a progressive collapsing foot deformity, and you can see what happens with the distance maps and the coverage maps in the peritalar area, but also talonavicular and ankle joint here. Here's just the same view, but looking into what happens with the distance maps in the tarsometatarsal joints. We also want to apply these concepts to surgical patients. So this is a patient of mine where I did the manual segmentation, and I calculated the coverage maps in the peritalar area. So you can see that this patient had 65% coverage of the medial facet before surgery, and a 47% coverage in the sinus tarsi. That should be 0. And after surgery, after multiple procedures, including, as you can see here, a medial displacement calcaneal osteotomy, also a lateral column lengthening, I was able to increase the coverage of the medial facet to 87% and decrease the sinus tarsi coverage to 10.3%. So doing this, you can give numbers to your patient of how good or how accurate was the correction and how better you were able to make the interaction between the hindfoot joints. We also want to apply the concepts to the ankle joint. So we're doing the same thing for the ankle, and this should be published hopefully soon. We're also looking into how conservative treatment with bracing and orthotics would be able to change those measurements and change articular coverage. We do believe that if you increase articular coverage, you improve joint interaction, you could potentially prevent the deformity to progress and also decrease the degeneration of the joint and arthritic degeneration of the joints. Another thing that we're doing is a lot of the problems with clinical and surgical studies for flat feet is that we usually don't do a single procedure. So you usually do a medial displacement calcaneal osteotomy, a lateral column lengthening, a gastroc recession, a peroneal tendon transfer, a cotton osteotomy or a lapidus. So you're doing more than one surgery. So we never know exactly which procedure is changing which measurement. So we're doing cadaveric studies where we're doing isolated medial displacement calcaneal osteotomies and doing simulated weight bearing in the weight bearing CT. And we're doing different sizes, different displacements, and trying to gauge how much this will change the measurements. One of the measurements we're doing the foot and ankle set, where we're doing pretty much every single flat foot measurement available in the literature. We're doing different sizes of cotton osteotomy and doing the measurements before and after surgery, so we can kind of gauge what happens with the measurements. Same for lateral column lengthening. And the next step will be to do with the soft tissue procedures as well. We're also combining them. Once we do the isolated procedures, then we mix, for example, 6 millimeter medial displacement calcaneal osteotomy, 6 millimeter cotton, 6 millimeter medial displacement calcaneal osteotomy, 6 millimeter lateral column lengthening, and seeing what happened with the measurement. We know that it's a long road, probably won't ever get to the final part of the road. I truly believe that sky's the limit for the amount of research that we can do. There's so many questions to be answered, but we should keep trying to head to make the difference in the life of patients, trying to answer the billion-dollar questions of what are the patients that need surgery, what are the patients that we need to pull the trigger sooner rather than later, and I think that is very important. The take-home concepts that I'm not sure how familiar you guys, I know most of you guys are radiologists, but I would like to emphasize the concepts of three-dimensional peritalar subluxation. The whole foot is dislocating underneath the talus, so we should try to avoid trying to isolate deformities in the sagittal plane, coronal plane, axial plane. Everything is happening at the same time, and we should keep that in mind. This is just a cadaveric video showing the concept that I was trying to sell to you. So I'm doing inversion and eversion. The only ligament that is still intact there is the interosseous ligament. So as you evert, there's a full stop. There's a maximum eversion where your lateral process will start hitting into the G-sane. After that, there's nowhere to go. There's no more eversion. So for you to keep everting your foot, you have to, now I'm going to go to the medial part of the foot. I'm doing the same thing, but you're looking from the medial side now. The only way, once you hit the sinus tarsi, the only way for you to keep going to eversion is to sublux your subtalar joint and sublux your medial facet that is right here. So keep in mind that. So again, for the take-home concepts or game changer concepts, in my opinion, start paying attention to the amount of valgus of your subtalar joint. That is an intrinsic risk factor for progressive deformity. Start looking to the subluxation of the subtalar joint, either in the posterior facet and or medial facet. Start looking to the presence of sinus tarsus impingement. Is a red flag for progressive deformity, and start looking into presence of subfibular impingement. Those are for sure, in my opinion, going to be the drivers for treatment of progressive collapsing foot deformity patients in the future. How do I apply these concepts in my clinic, to my patients? I always push the limits for flat foot reconstruction without fusions. Avoid hind foot fusions. Try to avoid them if you can. I tell my patients that if they have an increased angulation of their subtalar joint, they have higher risk of progressive collapse. If they have sinus tarsus impingement, I emphasize that it's not arthritis, that is an extra-articular impingement, but it is a red flag for progressive deformity. If they have subluxation of the medial facet, I tell them that that is potentially an earlier marker of progressive deformity, and is also a red flag, and we should follow up closely. If you have a foot and ankle set that is progressing significantly, it's also a red flag. And if you have subfibular impingement, it's a bad sign. We probably missed the boat because your interosseous ligament is probably gone. And in that scenario, you should consider a subtalar joint fusion. And we should always try to save the talonavicular joint and the ankle joints, because if you have to fuse the talonavicular joint, fuse or replace the ankle joint, then the outcomes will go down significantly. That's all I have. Thank you. I apologize for the long and dense talk. These are all my mentors and all the places that I've been during my career, and always had a great time. And this is my email if you guys want to contact me directly. Thank you so much.
Cesar, that was amazing. You gave me a vocabulary to describe what I see every day, and I haven't really had the proper terminology. The peritalar, the subtalar dislocation is really the key to everything I've been unable to describe. I have a couple of questions, and then I invite anybody to unmute and ask questions. You know, the term you came up with is progressive collapsing. So it sounds like, you know, once you enter that slippery slope, it's going to progress. Is there anything in this work you mentioned at the end that you're imaging patients, I suppose, in braces or orthotics that can slow or prevent the progression? Or is this something that I know you got rid of the word pediatric, or that the same way pediatricians are evaluating scoliosis, that you could give them some tools to identify the people at risk who, you know, might benefit from weight-bearing CT, or at least standard weight-bearing radiographs, where orthotics might be able to prevent or slow this. And then my other question is, well, I have a couple of other questions, but when you're making these measurements in your studies, how is it, it's always very difficult when you're comparing conventional radiographs to tomographic images in choosing the landmarks. Are you using the surface rendered MIPS to find your point and then picking the right location on the image slices? How are you picking the right slice to find your landmarks? Those are two completely different questions. But.
Well, yeah, well, you might have to remind. Lost part of it. It's saying that my connection is unstable, so you were cutting on and off here. But I'll try. I got the most of the important parts. So the first part is how do we define things, and maybe we could help even the pediatric flat feet. Yes, that's the billion-dollar question. I mean, we don't have the final answer for it, but I think we have much more indicatives of bad deformity. I just saw literally the last patient I saw in clinic before I joined you guys was a 23-year-old researcher out here of the university with a very asymmetric, bad deformity that is progressing. She came here and said, my foot is progressing, the deformity is getting worse. So she has progressive collapsing foot deformity. And I told her exactly what I told you now. I showed her the indicators, sinus tarsus impingement. She doesn't have subfibular impingement, and that is good. But the sinus tarsus impingement, she had about 35% subluxation of the subtalar, the medial facet of the subtalar joint. And I told her, look, I cannot force you to have surgery. You have a bad asymmetric deformity. You're symptomatic. You notice that it's getting worse. You're young. I think that if we don't do anything, this is going to get worse. But I cannot force you to have surgery. But if it was my foot, I would potentially have it surgically treated to avoid progression, or at least to decrease the progression. Regarding the kids, I don't think we have data to do that. It would be great if we have pediatric orthopedic surgeons involved with the research. There's a lot of misunderstanding regarding the amount of radiation. So a lot of people don't know that cone beam CT has a significantly decreased amount of radiation. So even parents and physicians are afraid of CT scanning kids, and I totally get it. I'm not saying let's do weight-bearing CT of every single kid that comes into your office, but if you have a symptomatic flat foot, I would say that it's probably the best indication for a weight-bearing CT in a kid with foot and ankle pathologies. So I think we need to study more, but for that to happen, we need pediatric orthopedic surgeons to get involved because for example, I don't see kids, and so I won't be able to start the process. But I do think that the same way we were able to find some markers of potentially progressive deformity in the adults, we would be able to find the same for kids as well. It might not be the same landmarks, but I think we would be able to find it. The second question about how do we decide where to do the measurements, that's a great question. So when I did my first publication at JBJS, and we made fun about that, we couldn't find a single publication, prior publication with simulated weight-bearing CT, or X-ray. Sorry, X-ray they wouldn't need it, but for the simulated weight-bearing CT, where they describe it perfectly how to get to the proper imaging. And that was the most difficult part of it. I think we spent at least 6 months to come up with a way to kind of address the images. So we have a specific way of doing every single measurement. So you need to develop a proper way, and there's no definite answer of how to get there, but I have my way of getting to every single one of the measurements that we did. For example, just to give an idea, for the medial facet subluxation, the way we do it is you go to your sagittal, in the MPR views, you go to your sagittal, you find the longest longitudinal length, A to P length of the medial facet, and then you bring your MPR, the cross-sectional, into the midpoint. So I would measure that. I would mark the midpoint of a measurement in the longitudinal length of the medial facet, and I would bring the MPR cross-section into that point, and that would give me the coronal plane view where I would do my measurement. But you have to be very methodical in the way you do it. And it's not just that. I mean, if you're using the MPR, you have to define what is going to be the axis of your alignment for you to use the sagittal. So it could be your second metatarsal. You could be a line between the second metatarsal head and the weight-bearing point of your calcaneus. So it depends on the way you do. If you're not doing the same measurements, if you're not using the same landmarks, you're going to get to different results for sure. And that's where the distance maps came to solve that problem, because then you're looking to the whole peritalar surface, and then it makes it the reliability to be much higher, because you're not going to a single image, you're assessing the whole surface. And then I think it's a much more robust measurement than just doing a single coronal plane measurement.
Are you more aggressive in when you pull the trigger in diabetics?
So that's a great question, because that was also questions about when we had the consensus meeting. We didn't want to include, so if you have a Charcot arthropathy and your foot is collapsing because your midfoot collapsed, you don't have progressive collapsing foot deformity, even though your foot is progressively collapsing. That would be a terminology only for flat feet patients that are collapsing. We wouldn't use that for Charcot arthropathy. But if you're coming to see me and you have a diabetes that is relatively under control, and we're not even considering Charcot arthropathy, my approach would be pretty similar to a person that don't have diabetes. I wouldn't change anything.
Okay. I'm afraid that I'm hogging the questions. Is there anybody in the audience who would like to ask Dr. Cesar de Netto any questions? That was really so illuminating for me, because I see all of these patterns that you're talking about, and I noticed that that really you're squeezing out the sinus tarsi by the subluxation of the anterior and middle facets of the subtalar joint. So you're straining the interosseous ligament.
Yeah, I think that, for example, the sinus tarsi, I have to prove that yet, but in my mind, sinus tarsi, everything, as you get more experience with the images with the patients, you change your concepts, and I think that's the cool part of medicine. But sinus tarsi impingement was actually considered a benign thing for flat feet. People say, yeah, there's a little bit of sinus tarsi impingement, and people would just say, okay, that explains the reason why you have pain on the outside of your foot as well. But that video, that cadaveric video that I showed you, is very important. So once you start hitting your lateral process into your G-sane angle of the calcaneus, it means that you exhausted the amount of eversion, or your foot is dislocating or subluxing, rotating under your talus. Once it rotates enough that your sinus tarsi is hitting your lateral process is hitting to the G-sane, there's nowhere to go anymore. So that's a sign that you're going to start, once you hit on the outside, I think that the progression of the degeneration of the medial soft tissue structures is like exponential. So sinus tarsi impingement means be careful and pay attention, because this is going to start going south pretty quick now.
So you started with the chicken and egg concept, but is it clear that, well, I don't know which came first, but is it clear that progressive collapsing foot deformity starts with a soft tissue lesion, or do you think that underlying abnormal geometry at that talus to posterior subtalar joint inclination is the slippery slope that stresses and degenerates and tears the soft tissue constraints?
Good question. I think you could have both. It's a multifactorial disorder. I think, for example, if you were born with a bad alignment of your subtalar joint, I think you were designed to develop a progressive collapsing foot deformity. It makes more sense to me that the bony part would start first. So bad relationship between the bones, bad alignment between the bones to begin with, makes more sense that your soft tissue will suffer with time. It's going to be overloaded throughout the years, and that will potentially stretch more your soft tissue, and then like you said, you are in that slippery slope, and then you're going to go. But I think as well, if you have a collagen problem, you were born with a collagen disease, or you have generalized ligamentous laxity or something like that, and you potentially don't need to have that bad alignment to develop the same thing. So I mean, I think they're acting together, being a multifactorial problem. If I could tell you what my hunch guess is, that most of the cases are bad alignment to begin with, and that starts degenerating the soft tissue. But I cannot say that the opposite could not happen as well. For example, in a collagen disease problem, I think it could happen the other way as well.
Okay, well, we're running over time. I want to thank you so much. Personally, I thought this was fantastic. I learned so much from you. Thank you.
No, it's my pleasure. Thank you so much for the invitation. Great pleasure. Wish you guys all the best. And if you want to reach me out through email, I'll put my email in the chat here as well.
Well, anybody, well, the video is going to be on the website, and so anybody can view that on demand, or people can contact me. I have your number.
I do have a. Oh yeah, you can give my number to anyone. No problem. I can put it here as well.
No. I was actually joking. I
Yeah,
meant I know how to find you.
Yeah, no, I'm here. I mean, we have a question from Marcelo Bordalo. That's a great friend and prior mentor from Brazil. I know you're close to him as well. Can I answer it, or I can answer to him as well later?
Yeah. Go ahead, answer.
So he said, any application in tarsal coalitions. Like I said, I don't see kids, so I probably don't see most of the tarsal coalitions that come to University of Iowa, but I do see adults with tarsal coalitions. And I think that it will be different for tarsal coalition patients than it is for the traditional progressive collapsing foot deformity. Because if you have the tarsal coalition, the development of your bones was different. I think that yes, a tarsal coalition can put you into more valgus, as we know, because the bones are going to grow with let's say this growth arrest that is the coalition. So we grow into potentially more valgus, even though we know that tarsal coalitions can have varus alignment of the hindfoot as well. But we don't. Answering your question, Marcelo or Bordalo, the way I call him, we don't have a lot of data for tarsal coalition, but I do think it makes sense to see tarsal coalition patients with the weight load in the CT scan, because I think the alignment will change.
Okay. Damien Sacco asked, talus angle in kids. I don't know really.
Yeah, I saw that. I didn't understand exactly.
I don't think he's with us anymore, so I don't know how to address that. Okay. Well, I think that wraps it up. We all need to let you get back to work, and I'm sure everybody's got the list pressuring them. So thank you again, and I'll let you know when we have the video available for viewing.
Excellent. Well, thank you so much, Hillary, for the invitation. It was a great pleasure, great honor, and I hope it was helpful for you guys.
Absolutely. Thanks. Bye-bye.
Bye.